In this case, we will share together two different types of hysteroscopic pathology. The patient had a previous history of a cesarean section, followed by intrauterine adhesions and secondary infertility. So when we go through the cervical canal, we face this very viscid, thick, cloudy mucus, which is mixed with blood, and this is a characteristic of cesarean scar niche, or the famous name ismocele. So slowly going through the cervical canal, don't go quickly, otherwise the cloudy mucus will cover the lens and you might go into a forced track or a perforation. So the very important first tip in insertion, give it time and use whatever proper or maximum fluid jet to clean the cervical mucus. Direct the tip of the telescope toward the cervical glands, and that will help in squeezing the mucus out from the endocervical gland. It's very obvious here. You see here, I'm spending much more time in the cervical canal before entering the cavity, and using, as I said, the force of fluid jet to squeeze the mucus out and clean the cervical canal. So slowly we do this procedure. Take it maybe a few minutes, like I'm doing here. The cervical mucus looks like a threads. It's very viscid, and it might cover the lens and you go into a wrong direction. Follow the lines of the endocervical canal. They look like tram line or railroad lines. This is your landmark or your guide to know the direction to the internal os. Approaching to the internal os, it's very dark because there is a lot of blood collection in the pouch of the caesarean scar defect. Here, you see that? And in my opinion, this is the pathogenesis of the ismocele, which causes pain, infertility, continuous bleeding, because the mucus and blood collect in this pouch and continuously dribble and trickle all through the months, causing this troublesome, awkward, irregular bleeding. And definitely it is like an obstacle for the sperm migration or going through the cervical canal to the cavity. Look at this. All these viscid, dirty mucus and blood was actually in the caesarean scar pouch or defect. Let's go in and see more pathology. And as I promised you, we will share together more pathology in this case. So after cleaning the mucus and the blood inside the cavity, and this is achieved by an intelligent, judicious use of the inflow, outflow. Hysteroscopic surgery is not like laparoscopy. Laparoscopy, you have inflow and the outflow is suction. But here, don't do suction. If you apply suction, the walls will collapse. I know that it is a common teaching that suction to clean the cavity, but in my personal opinion, no. Just open the outflow and the negative flow of the fluid will clean the cavity. Here you see an abnormal, bizarre endometrium. Look at this comma shape, vessel. This is a dysmorphic endometrium. There are two opinions about this dark comma-shaped signs. Some people claim that this is a thrombosed blood vessels. Others say that this is an endometrial glands congested with blood. Up till now, I cannot put a clue without an evidence, but this is a dysmorphic endometrium. Maybe taking a biopsy can help. Looking inside the cavity, an identification of the topography is achieved by locating a landmark, which is a tubal ostium. And obviously, there is an intrauterine adhesions followed the cesarean section. This is a landmark, one tubal ostia, and there is a central band, thick band of adhesions. So, dealing with an intrauterine synechia or adhesions, there are two options: either to use the electrocautery resectoscope or the scissors, as I am doing here. Definitely, scissors are preferable because it inflicts less damage to the endometrium. Electrocautery cut, coagulate, and the heat thermal spread might affect the already weak, poor endometrium. So, working with the scissor actually requires more skills than working with the resectoscope. I mean in cutting, not in resection. In myoma, resection is different. So you have to train yourself how to work with the scissor by moving the scissor in and out to reach the pathology you want to cut, or fix the scissor and move by the whole system in and out. So people ask me, Osama, which way we do? Actually, you have to play both. You cannot apply, I get amazed in some training program, they say certain rules like only move the scissors in and out. This is not actually practical. Sometimes you need to fix the scissor position and move the whole system. Like now, I'm fixing the scissor and move the whole system in and out. Also, you have to train yourself how to rotate the scissors. And this is by the hand grip. You have to see it to know how to do. To rotate the scissor, to adjust the direction of the blades in the proper direction, correct direction to cut the tissues. Meanwhile, the orifice on the sides, as I diagnose it as a tubal ostium, could not be the tubal ostium. Could be still there is an access to more deeper space. So how to know this is difficult to go by the telescope in this narrow opening. So just push the scissor through this opening like I'm doing here, and this will help you to know how deep is the way or the recess. Same like a blind man using the stick to know the road, okay? So follow the scissor procedure. I'm coming back with more and more tips. In fact, dealing with this central adhesions very much looks like a uterine septum because it is thick, broad, and extend from one ostium to the other ostium. So the maneuver and the technique looks exactly like expansion or release of a uterine septum. So because of the poor endometrium and the possibility of recurrence of adhesions, it is advisable to put a physical barrier to prevent coaptation of the walls of the uterus and to prevent reformation of the adhesions. There's so many ways, like using an intrauterine device or gels or whatever, or a membranes, but I find that the Fool's balloon is the most optimum physical barrier, and I prefer to inflate the balloon under vision. So this will help you how many milliliters to inflate. It's difficult to estimate that blindly because if you put too much, it will be very painful. If you put too little, it will fall down. My dear friends, I hope that these tips and tricks help you to master intrauterine surgery. Osama Shawki from Cairo, Egypt.